This conference will now be recorded.
ఎప్పుడున్నారు జేపీ ఉందా లైన్ జేపీ అక్కడ సిఆర్ క్లాస్ లైన్ కి వచ్చేసారు జేపీ మైక్ ఎక్కడ రాజేష్ ఇదే నా మైక్ జేపీ ఎలా రాజేష్ అది మన వీళ్ళు ఉన్నది ఇదేనా ఎవరెవరు ఉన్నారని ఎలా మనకి లిస్ట్ ఒక పేర్లు వస్తాయి ఇది జేపీ జేపీ తెలుసులేదు 30 తన్మయి రోల్ నెంబర్ 30 తన్మయి జ్యోతి ఉన్నాడు ఆన్లైన్
హలో
వినిపిస్తుందన్న
జ్యోతి who is speaking? Identify yourself. Hey, can you identify who is speaking to me?
సుజిత్
వినిపిస్తుందా సుజిత్ వాయిస్
వినిపిస్తుంది
is my screen shared ante can you see my pdf? Are you able to see the pdf?
కనబడుతున్నాయి సార్
మనం ఇట్లా చేసినప్పుడు వాళ్ళు కూడా అంతే అవుతుందా ఓకే ఈశ్వర్ నంబర్ 33 ఈశ్వర్
గ్రీన్ ఉంటే అది స్క్రీన్ షేర్
ఓకే ఇప్పుడు కాదు ఇంకా క్లాస్ చెప్తే వీళ్ళు క్వశ్చన్ చదువుదామని వీళ్ళందరూ రత్నహరిత 34 రత్నహరిత 35 గాడిపాటి బిందు లక్ష్మి 35 గాడిపాటి బిందు లక్ష్మి 36 రేవంత్ 37 లోహిత్ 38 భూషణ్
Sir, present sir.
38 Bhushan.
Sir,
Bhushan,
38 present.
you're
Sir.
online.
Yes, sir.
Okay,
Yes, sir.
Bhushan, was the PDF shared to you the last time? What whatever I taught you was the PDF shared to you, right?
Yes,
Sir, 37 rand, sir.
37 present, sir.
Okay, 37 Lohit. Okay, 37 Lohit and 38 Bhushan. You just wait. 37. I just want to Lohit. Was the PDF shared to you last time? Did you read about laryngeal paralysis?
Yes, sir.
Okay, tell me what are the abductor muscles of thyroid? Sorry, larynx. Am I talking to Lohit, right? 37 Lohit.
Yes, sir.
Yeah, I've asked you a question, Lohit. Can you answer that?
Posterior Crico Thyroid, sir. Abductor.
Okay. Mohit Bhushan,
Sir, yes, sir.
you're online, right? So I just want to
Yes,
ask
sir.
you, what are the adductors?
Present, sir.
39 Geetika.
Sir, thyroid retinoid,
Okay.
Crico retinoid,
Crico Thyroid.
lateral Crico retinoid muscle.
Sorry. Okay, fine. You read once again.
Okay, sir.
Geetika 39.
Yes, sir.
Geetika 30. So Geetika, you have read? No, what nonsense? Seriously, just Geetika.
Yes, sir. Yes, sir.
Uh, can you just tell me the adductor muscles? Whatever he told me, I just want you to tell me what are adductor muscles.
Sir, thyroarytenoid, transverse erythroid, lateral cricoarytenoid, and cricothyroid.
Okay. Any name? Any other name you know for thyroarytenoid?
Uh, sir, no, sir.
Okay, fine. Okay. Vanishri Siri 40, roll number 40. Vanyasri 40.
Present, sir.
Yeah, you're present. I can see you're present here. So, what else? Can you tell me about Siemens law?
So, uh,
Vanyasri,
sir,
have you
uh,
what?
abductor
Siemens
muscles
law.
are paralyzed.
Yeah.
Sir, abductor
Listening.
muscles are paralyzed.
Okay.
Uh, More susceptible, and they are
No, so you don't tell me what is. You don't have to explain Siemens law for me, but just tell me for for what purpose the Siemens law has been used. At least tell me in which case Siemens law has been used. For what? What it explains. You don't have to tell me the gist of it. Just tell me for what. Just one single line. Just in single line. For what purpose Siemens law is used.
uh, unilateral recurrent nerve paralysis used.
Okay. Okay. Fine. Next 42 Bhavana Gummadi. 42 Bhavana.
Sir, sir, present.
Yes, Bhavana. So Wagner-Grossman hypothesis. You have idea about that?
Same, sir.
Wagner-Grossman hypothesis.
Recurrent laryngeal nerve palsy. Muscles are palsied except cricothyroid, sir.
Okay. So, okay, fine. Srujana, 44.
Yes, sir.
Tell me, can you just come to a place where your TV is not on? Srujana. Srujana.
Yes, sir.
Yeah, can you tell me the nerve supply of Crico Thyroid?
Sir,
Nerve supply of Crico Thyroid.
external branch of superior laryngeal nerves.
Okay, fine. Vamsi Krishna, 45.
Sir, sir.
Oh, Vamsi Krishna, you're there. Can you tell me what is the
Sir.
sensory supply of vocal cords, above the vocal cords?
Internal branch of superior laryngeal nerves.
What?
Internal
No,
branch
repeat
of
once again.
superior.
Very good. Yeah, okay, very good. Okay, fine. Chava Harini, 46.
Sir,
Yeah, can you tell me the below the vocal cord sensory supply, Amma? Harini. Below the vocal cords.
laryngeal nerves. Recurrent laryngeal nerves.
Very good. Okay, fine. Okay, what? Okay, yeah, you can go. Listen to the class. What I'm going to say now. Okay. 78, Sharath. 78, Sharath. 78. Okay. Absent. 76, Manasa.
Sir, yes, sir. Present, sir.
Yeah. Okay, Manasa. Now the point is, can you just tell me what now supplies all the intrinsic muscles of larynx?
Recurrent laryngeal nerves.
Except any muscle, any exceptions are there?
Cricothyroid, sir. Cricothyroid, sir.
Okay.
Supplied by
So,
external branch of superior laryngeal nerves.
what?
Cricothyroid is the exception muscle, sir.
Yes. Okay, fine, good. Next, Manikanta, 94. Manikanta,
Sir, yes, sir.
Manikanta, you're there.
Sir?
Can you see the screen now?
Yes, sir. I can see the screen, sir.
I mean, like you're able to see the picture, or you can just. I mean, I just want to know whether you can move the PDF around, right?
Yes, sir.
So you're able to see the cross section of this larynx cross section, right? You're able to see that.
Yes, sir.
Okay. Now you be online. So let me take the class now, just so that you can let me know if there is a problem with the voice or voice clarity or anything like that. So I want you to be online. Okay. Listen to
Okay.
what I'm just going to revise the basics once again. Let us see. I hope you guys understand something. So anyway, just be online. Okay. Okay,
Okay, sir.
now as I see, if you're able to see the pointer right, I'm able to point the arrow right. You're able to see the arrow.
Yes, sir.
Okay, fine then. Okay, now as I just want to explain, this is the epiglottis. Okay, general. Let us go for general. We are. This is the epiglottis here. This is the epiglottis. Epiglottis. This is the hyoid bone here. See, hyoid bone is dividing the epiglottis into suprahyoid epiglottis and infrahyoid epiglottis. This is the hyoepiglottic ligament. Okay, this is the hyoepiglottic ligament because it's connecting the hyoid to the epiglottis. This is the hyoepiglottic ligament, and this area, this is the epiglottis, and anterior to this is the pre-epiglottic space. So you can see there's fat in the pre-epiglottic space. So remember that this is the epiglottis. Epiglottis has two surfaces. This is the anterior surface, this is the posterior surface. Anterior surface is called the lingual surface because you have the tongue here. Normally there will be a tongue, base of tongue will be here. So this is the this epiglottis has two surfaces. One is the lingual surface, posteriorly is the laryngeal surface, because this is the larynx, so this will be the laryngeal surface. So epiglottis has two surfaces. So one is the laryngeal, this is the laryngeal surface, this is the, what to say, this is the lingual surface. Okay, so now again you can see that this is the thyroid cartilage here, and I told you this is the hyoid, this is the hyoepiglottic ligament, and you can see this is the hyoid and the thyroid, right? There is the thyrohyoid membrane because it's connecting the thyroid cartilage to the hyoid, so this is the thyrohyoid membrane. So this is a thyrohyoid membrane, and the thing is that next thing is that you can see this is the thyroid cartilage. This is thyroid cartilage, and you can see on the what to say. This is the thyrohyoid membrane. This is the thyrohyoid membrane. Okay. The next is that you have the arytenoid cartilage. This is pyramidal in shape, and you can see this is the vocal process, which has the vocal cords connected to it, which connects the anterior part of the thyroid cartilage. And this is the posterior process, also known as the muscular process. Okay, so the muscular process and the vocal process. Okay, you have the vocal process getting connected to the vocal cords, and muscles are getting attached to the arytenoid cartilage. Now you can see this is the cornicate cartilage here, and this is the cornicate cartilage, and there will be another cartilage which is the cuneiform cartilage, which is not seen here. It will be in the AE fold. You know what epiglottic fold is? Nothing but there's a fold, there's a mucous membrane passing from the arytenoids to the epiglottis. It will be like this. So in that there will be the cuneiform cartilage. So these are the cartilage, and you can see this is the cricoid. See the cricoid in the sagittal, in the cross section. Can you see this is the sagittal section we are seeing? You can see the anterior surface is very small and the posterior surface is very big. I mean the centimeter. It is the height is there is a difference in the height. See, this is the posterior surface of the cricoid. This is the anterior surface here. Cricoid is the complete. It forms a complete ring. It's called signet ring up. It has a signet ring shape, and the cricoid is the only cartilage in the larynx which has a complete ring. So that you remember that. This is the cricoid cartilage here. Okay. Now, based upon this, I told you about the wheel. Okay. Now, can you see the muscles of larynx here? I just want to see this is the muscles of larynx. The first muscle I told you is. Let us talk about the adductors here. Now, adductor, I told you there are two. There will be first is the thyroerythroid. Thyroerythroid. There are two parts of thyroerythroid. Remember that. Two parts is that one is the thyroerythroid, which is the external part, and the another part is the vocalis muscle. So class. Okay, next thing, see. So this is the thyroerythroid. This is the as we spoke about. Thyroerythroid is the first adductor, and this is the vocalis muscle. So remember that thyroerythroid has two parts. One is the vocalis, which is the internal part, which lies next close by to the vocal cords. This is the vocal cords connecting the vocal process to the arytenoids. It starts from the vocal process to the arytenoids to the thyroid cartilage here. This area is the anterior commissure. Anterior commissure is nothing but the meeting of the two vocal cords known as the anterior commissure. Okay, remember that. So vocalis, thyroerythroid, we are talking about the adductor. I told you thyroerythroid has two parts. One is the vocalis muscle, the other is the thyroarytenoid part. So vocalis muscle is the internal part and the thyroid is the external part. You know thyroarytenoid external part is an adductor, right? So it adducts the vocal cords, whereas the vocalis muscle is involved in the what is it, tensing the vocal cord. So this is the tensor of the vocal cord. Remember that vocalis is the tensor of the vocal. So it increases the tension of the vocal cords. So for a female voice, that pitch has to be more. So remember, in a female voice, the pitch has to be more. So when the cords are floppy, in say, let us say, recurrent laryngeal paralysis, where the thyroarytenoid is lost, right? So when the cords are floppy, what happens? The voice is lost. So that is why female voice have high pitch. Remember that. So the pitch of the high pitch is maintained by the vocalis, which tenses the vocal cords, which pulls the vocal cords, which makes it taut. When it is floppy, the female voice is lost. So remember that. So in the thyroid and raising the pitch of the, even raising the pitch of the voice is also important, which depends upon the vocalis muscle. So these are the one. So the first adductor is covered. Next you have the transverse erythroid. You can see this is the transverse erythroid. See, this is the transverse erythroid, where it is attaching to the muscular process of the thyroid, erythroid, and it goes to the other muscular process of the other erythroid. So transverse erythroid, remember that this is the only muscle which is the intrinsic muscle of larynx, and it's also known as intra-erythroid, and it receives dual supply. A transverse erythroid receives dual supply from both sides, and so it will have cross innervation also. So transverse erythroid in unilateral laryngeal paralysis, it can some part of transverse erythroid can receive it from the other side also. So this might be preserved in some cases. So remember that transverse erythroid is also known as inter-erythroid. So this receives dual supply, and this is the so connecting the muscular process to the other muscular process. This be like this. So this will be here. It will be. So this is the transverse erythroid. Next you have the then what are the next you have the lateral cricoarytenoid. You can see the lateral cricoarytenoid. This is the cricoid here. Again, from cricoid, this is the cricoid. From the cricoid, it is getting attached to again to the muscular process. This again it's getting attached to the muscular process of the erythroid. So this is the lateral cricoarytenoid. So next we have the Crico Thyroid. So Crico Thyroid is nothing but it attaches the cricoid to the thyroid cartilage, which this obviously this picture doesn't have the cricothyroid muscle here. So remember the cricoid. So adductor muscles have been covered now. So Crico Thyroid, from cricoid to thyroid cartilage, it will be like here. So cricoid, generally it will from cricoid to this is the thyroid cartilage. So cricoid, from this to cricoid to thyroid. This is the lateral cricoarytenoid. Next is the only abductor muscle, which is the posterior cricoarytenoid. So from posterior cricoarytenoid is nothing but where it attaches to the posterior part of the cricoid. It arises from the again it arises from the muscular process. Remember that all muscles of getting attached to the erythroid will gets attached to the muscular process. So posterior cricoarytenoid is nothing but derives from the erythroid from the muscular process and gets attached to posteriorly to the cricoid. You have the cricoid. So here it will be the cricoid. So posterior part it gets attached. So that's why it's called posterior cricoarytenoid. So we have covered the muscles of intrinsic muscles of larynx now. So adductor and abductor. So remember that. And we spoke about the nerve supply also. Actually, this lesson is almost over. There are only, I told you about recurrent laryngeal unilateral. I even taught you about recurrent laryngeal paralysis unilaterally, and there is bilateral recurrent laryngeal paralysis. I taught you about that also. And then now coming to the, let me tell you about you are supposed to be thorough with the transverse chordotomy Kashmir operation and all that. So now the thing is that we are talking about combined paralysis. We are talking about now combined paralysis. That is both recurrent laryngeal nerve and the superior laryngeal nerve paralysis. In recurrent laryngeal nerve, you lose the motor supply of intrinsic muscles of larynx. In superior laryngeal nerve paralysis, you lose the motor supply and the cricothyroid motor supply. You lose the sensory supply and also the motor supply for the cricothyroid superior, because superior laryngeal nerve has two branches. One is the internal laryngeal nerve and the external laryngeal nerve, external branch. So so external branch in the superior laryngeal, the external branch supplies to the what? Crico Thyroid, and the internal laryngeal nerve of the superior laryngeal nerve, internal laryngeal branch of superior laryngeal nerve it gives the sensory supply, right? So now, so sensation is lost, Crico Thyroid is lost, all recurrent laryngeal nerve is lost, so all the muscles of totally, so you have lost the sensation, you have lost all the motor supply of the intrinsic muscle of larynx. So now the point is that since that, so you can in case of unilateral, all except intrarythenoid is lost, because I told you intrarythenoid has a dual nerve supply. It can receive from the other side. That is why intrarythenoid is not lost in this case. Remember that I told you that point. So in case of combined paralysis of recurrent and superior laryngeal on unilaterally, all muscles are lost except the intrarythenoid muscle, which has a dual nerve supply, which is like intrarythenoid is also known as the transverse erythroid, which is an adductor. So again, this will be the cords will be in adducted position. Okay, remember that again. So now, what is the etiology of the combined nerve paralysis? Etiology is the thyroid. You have the the thyroid surgery is the most common cause of unilateral, both recurrent laryngeal nerve and superior laryngeal nerve paralysis, because thyroid. When you see this picture here, uh, we have when thyroid will be here. Thyroid will be here. So when you are doing a surgery, what happens is when you are you have to remove the superior pedicle. Here there will be superior thyroid artery. Superior thyroid artery will be here. So when you are the superior thyroid artery, when you have to ligate the superior thyroid artery to remove the superior pole of the thyroid. So what happens? There is high chance of injury to this superior laryngeal nerve here. This is a superior laryngeal. So that is why during thyroid surgery, even superior laryngeal nerve might be injured. And when coming to the inferior pole, you might damage thyroid will be here. So when damaging when removing the inferior pole, you might damage the recurrent laryngeal nerve. Again, this might cause the superior laryngeal paralysis and also the recurrent laryngeal paralysis. Only in this case, the sensation is lost. All the muscles of larynx are lost, except in unilateral cases, except intrarythenoid, all muscles will be lost because the intrarythenoid has a dual nerve supply. So that point you have to remember in case of. Okay. Now, in case of in case of uh, the okay. Now, unilateral we're talking. It may also occur in lesions of nucleus ambiguous, that is in the brain, in the medulla, or that of the vagus nerve proximal to the origin of superior laryngeal nerve. That is high vagus lesions. Okay. Thus, lesions may lie in the medulla, posterior cranial fossa, jugular foramen, or the parapharyngeal space. So all this, but remember, thyroid surgery is one of the most common cause of unilateral, bilateral, unilateral both nerve palsy. So what are the clinical features coming? So all the muscle of larynx of one side are paralyzed. Vocal cord will lie in the cadaveric position, that is 3.5 mm on the midline. So what is the cadaveric position here? This is the cadaveric position, which is nothing but the intermediate. I told you that adduction is there. So that is why adduction by intrarythenoid will be here. So that will be it. That is why it is little bit that is why it will be here, not rather than the median or paramedian position. So it will be in the cadaveric position. I told you that intermediate position is where the vocal cords come, and from here, in the normal cases, from this is the place where it might adduct, it might abduct. So this is the intermediate, this is the position. So it will be lost, it will be in this position only. So intermediate position. Okay. So normally normal vocal cords come to intermediate position and then move close to each other or move away from each other during breathing. So but now this will be in the intermediate position, also known as the cadaveric position, which is nothing but 3.5 mm away from the midline. So now what happens? So what is the so vocal cord will lie in the cadaveric position, that is 3.5. The healthy cord is unable to approximate because it's very far. In median paramedian position, I told you that it might come close, but in the cadaveric position, the other vocal cord can't vocalize. So thus causes glottic impedance. So there will be portions of voice, there will be aspiration of liquids because we have lost the sensation. There will be aspiration of liquids to the glottis now. So cough is ineffective due to air. Cough is ineffective also. So any foreign body goes because of the sensation is lost. Any foreign body entering into the larynx, what happens is you immediately cough, right? That is why you get the cough sensation when you speak while eating. But what happens? The cough is ineffective because the vocal cords has to be close together for the cough. See, for the pressure to build up from the lungs, the air comes out. So when you cough, what happens is the vocal cords are in closed position, and the pressure builds up, and then it releases so that the foreign body comes out. But now, because of this, the vocal cord lies in the what's the cadaveric position. Whatever the pressure can't be maintained, so whatever the cough is totally ineffective. So the cough is ineffective due to air wastage, because the cords are supposed to be here. It is here now. So what happens? The cough will be the pressure won't be maintained. The air coming out will be escaping. So there won't be loss of voice, and also there will be the cough will be ineffective, and because of the loss of both nerves and the sensory supply, sensation is also lost. So there will be you will have the what is it? You will have the aspiration. So remember that. So now this completes this chapter in this completes the chapter of the recurrent laryngeal paralysis. I mean this paralysis. Okay, now type 1 thyroplasty. I spoke about type 1 thyroplasty. So remember the type 1 thyroplasty, you do medialization of the vocal cords. So whenever, for example, I told you that there will be in the recurrent laryngeal paralysis, the vocal cords will lie in the median or paramedian position. So what happens over a period of time? We wait for 6 to 12 months when the we see to that cord medialization occurs. I mean, the other cord will generally come together to to normalize the voice. But there will be but in those cases where the vocal cords has not been where the vocal cords has not been not been approximated by the other vocal cord, what we do is we do a thyroplasty type 1. This is that Ishiki thyroplasty type 1, where you put a small hole in the, I mean, you open this, you open the neck in the midline, which is nothing known as the laryngeal fissure. Laryngeal fissure operations are nothing but you open the neck in the midline, you access thyroid cartilage, you measure this, you open this thyroid cartilage here, you create a window in the thyroid cartilage here. Then what happens? You put a small block. This is the silicone block here, and then you put it here. So what happens? The silicone block push the vocal cord. Since this vocal cord is paralyzed, so it will be in this position. This will be held in this position by this by this silicone block. Now this vocal cord will be moving, will be approximating here and there. So the voice will be better, but not compared, not to the normal voice. So it will be better than the hoarseness. So, and also there will be and also there won't be any aspiration, because the vocal cords can be prevent aspiration by this. So remember, the type 1 thyroplasty, you medialize the lateralized vocal cords. So now you put a silastic block. Normally the vocal cord will be lying here in the median of paramedian. Since you have this push the vocal cords together, so now it will be able to meet with this. Now coming to the bilateral condition. What is the bilateral condition of the both muscles? Like bilateral is you have lost the recurrent laryngeal now, you have lost the superior laryngeal now bilaterally. This is a very rare conditions. All muscles are paralyzed. So what you do so there will be total anesthesia of larynx. The sensation, there will be asensate larynx. Both vocal cords lie in the cadaveric position. So there won't be both lie in the cadaveric position. So so what happens now in this case? So what are the causes which leads to the bilateral cause of that? So important causes include surgical or accidental trauma, neuritis, mostly diphtheria, and pressure by cervical nodes, or involvement in the neoplastic process. So any neoplastic process where which is causing this, you can operate upon. You can go for radiotherapy, or you have to look for the underlying causes leading to it. Okay, now the point is, what happens to the clinical features? The patient, there will be aspiration. Why aspiration? Because the total sensation of the vocal cords, that the larynx is totally asensate. So there is no sensation. There will be larynx aspiration. Aphonia, because both the cords lies in the cadaveric position. Because previously I told you that one vocal cord will be functioning, the other vocal cord will be in cadaveric position because of the transverse erythroid. But now all muscles have been lost. Aphonia will be there, so he won't be able to speak, because there will be loss of voice, because both will be in the cadaveric position. So there won't be enough. The vocal cords won't approximate for the voice to be generated. So then there will be inability to cough. I told you that there will be bronchopneumonia. Bronchopneumonia is because due to aspiration, you might get into the pneumonia, aspiration pneumonia. Now how do you treat? So you have a choice. Either you do a tracheostomy, so he won't be able to talk. Only thing is that you have saved the person's life by doing a tracheostomy, because every time there might be a problem with that because you won't be able to, but you have prevented the airway. So the tracheostomy, you do a tracheostomy, or to prevent, you can do a epiglottoplexy to prevent aspirations. So what do you do in epiglottoplexy is you put the epiglottis back, you suture it. See, this is the let me go to the first picture. This is the epiglottis, right? Which this is the inlet of larynx, which goes through the air goes through the cricoid into the lungs. So what you do epiglottoplexy, where you tie the epiglottis here so that this larynx, and you do a tracheostomy. This epiglottis will prevent the air, will prevent the food entering into the larynx. So epiglottoplexy is nothing but you use the epiglottis to prevent aspiration, and you do a tracheostomy. So you have taken care of the voice, airway, and you are closing the epiglottis on the on the larynx, so that there won't be any aspirations. So you do epiglottoplexy, and or you can go for total laryngectomy. You directly remove the larynx, so that, and you do a tracheostomy, so there won't be any voice, only that there will be an airway tracheostomy, there will be a permanent tracheostomy done. Next, diversion procedures. I don't think see, diversion, I'll just let you know if you can understand. See what happens, you have brought the trachea out, this is the tracheostomy here, and you have diverted the larynx, upper part of the larynx, into the esophagus here. So whatever food you eat goes to the, I told you, whatever the food you eat goes to the esophagus, right? Normally. So if at all any food particles enter the larynx, it will be trapped again into the esophagus. So that is how it is. This is the diversion. This is the diversion procedure you do in the case of bilateral complete recurrent and superior laryngeal paralysis. Now type 2 thyroplasty. This is the first one we spoke about. What's the medialization of the vocal cords? This is the thyroplasty type 2. This is the lateralization thyroplasty. So lateralization thyroplasty, when both vocal cords are together, when there are no, see, when there are no you lateralize the vocal cords, because air has to escape, otherwise he will be, what to say, the air can't come out, so he'll be in, so he won't be able to breathe through the larynx, because the vocal cords will be affected. So in that case, you do a lateralization thyroplasty, where you open the midline of the thyroid cartilage. You put a small block here. The silicone block will be put here, so that there will be a gap formation, because the vocal cords are attached to here. So this will be the opening. So see, you can see there's a space here now created. So this is the lateralization thyroplasty. There is other type 3 and type 4 thyroplasty. Type 3 thyroplasty it is done for males, where you shorten the vocal cord, and shorten the vocal cord for males. That too, you do it for puberphonia. I think I told you about disorders. I spoke about puberphonia and disorders of voice, where males are more attached to mothers. Will have they won't have a crack in voice. So there'll be length. I mean, the vocal cords will be length. Will be more tensed. So what you do is you decrease the tension of the vocal cords by shortening the vocal cords. That is the type 3, where you correct the puberphonia. You do it for males who have voice of females. So that is puberphonia. In type 4, you do for androphonia, for females, where you lengthen the vocal cord. Okay, you lengthen the vocal cord. I told you for females have high pitched voice, so there has to be lengthening of the vocal cords. Lengthening is done by the thyroerythroid muscle, also the vocalis muscle. Remember that. So now for female, type 4 thyroplasty is done for females. For example, in androphonia cases, where females who have a male voice, or in section procedures where a male has been converted into female. It's her choice. So now she wants a female voice also. She can go for a, he or she can go for type of thyroplasty, where she'll have a female voice. Male is converted into female in section procedures. So remember, type 1 is medialization, type 2 is lateralization, type 3 is shortening, type 4 is lengthening. So type 3 is done for puberphonia for males, type 4 is done for females. who has male voice, and type 4 is also done for a male who wishes to get converted into female. So that concludes the recurrent laryngeal paralysis. I hope, please go through it once again. I've shared the PDF to you. This is one of the important chapter. You might get the Siemens class of 2 marks, or you can get the recurrent laryngeal paralysis of 4 marks. So just understand that, and I think next lesson we'll go for another new chapter. JP, are you there? JP, who is online? I asked someone to be online. What's your name?
Sir, Manikanta, sir.
Yeah, Manikanta. Manikanta, I just want you to do. You and JP discussed what chapters in Larynx are still have not covered. I want the chapters of Larynx to be. I mean, what chapters have not been covered. I just want to make a list of it and take a photo of that. Write it down. Take a photo. Take a photo of that and send it to me to my WhatsApp number. JP has my number. You can have it from him. So I want you to discuss among yourself. Let me know what chapters have to be covered, because another 1 month I think we have to go into revision of all chapters of ENT. So ENT is done with another one. They have told us that you have to complete it by this month. So I think hardly 2 or 3 chapters will be left. I just want to know what chapters have been left. So please let me know. So I'll conclude this chapter. I mean, what say? I'll conclude this session today. Okay.
Okay, sir. Thank you, sir.